And hello. Hi, it is Kathy Frey here from IMCO, from the International Integrative Maternity Healthcare Organisation, and welcome along to actually the first webinar for 2023. Had a nice little Christmas break with everybody there, so it's great to start to see you all back on board and life returning to out of Christmas time. And welcome along today is Rixa Freeze. So Rixa, say hello.
Hello. Nice to be
and
here.
For those of you here today, joining us live, and those watching later, of course, we've had quite an interesting topic that we wanted to go over today. It's really a bit of a reflection takeaway on what has occurred for David and Kristine and Rixa, the Breech Without Borders team, who have just spent at the end of last year a couple of months extensively in New Zealand and Australia teaching breech birth, and what was their takeaway and what was sort of going on, and be interesting to hear all that. Now, Kristine, who some of you may have seen before on webinars, she is unable to make it today. And she's very sad about that. Yeah, she is, let me just kind of see her little note here. She is unfortunately able to make it because she is working in Egypt currently. So she just can't quite fit that all in. It's not really quite coordinating. She absolutely loved her time in New Zealand and Australia, and got lots of great feedback from the workshops that they ran. But Rixa is the founder of Breech Without Borders, so we've got a really good webinar planned here for you guys today, of some great interesting information, and David may make it. Do you want to give David's latest update? I thought that was quite hilarious.
Yes, so a few hours ago I checked in with David to see how he was doing, and he says, I have a GI bug that is relentless and has me in bed. I have 2 breaches in Charleston, 5 hours away, one in labor and the other one whose water broke yesterday and is rumbling. I have a midwife in Florida with a partially retained placenta. Obviously, he's assisting her over the phone. So if he's not here, it's likely because he's on his way to one of these births and or puking in bed, or maybe both, hopefully not at the same time. So he's hoping to join us, but I'm guessing that if he doesn't pop up in the next few minutes, there's a lot of things going on with his life today. So
right. And and all those midwives and obstetricians out there certainly understand that, and all the doulas.
yes.
Yeah, so do you want to give us start perhaps with an overview of what your team was doing, and I guess sort of what you were expecting, and the differences between that and how things actually panned out?
Yeah. So we started teaching late October when David flew over, and ended teaching in December 20th. What was the last workshop day? 20th, I think. 22nd, maybe, in Tasmania. So it was a really packed 2 months of traveling and teaching. Oh, David's here. So happy that he's
coming in.
Wonderful.
Yay!
All right.
Hey there, David.
Fingers crossed, David, that you would make it. You've got a lot of busyness going on today.
Yeah, it's a pretty strange day. So I may nod out and I may drop out and take a phone call and get back in or something. We'll see. I might be coming and going. So
sure.
That's all great. We've only just sort of started, and Rex is just starting to give a little bit of an overview of what of you guys' experience teaching in Australasia.
Yes, I was just overviewing that you started late October, and we, as a team, one or more of us was teaching through almost right up to Christmas. And that's about as far as I got, and you popped on. So we were in so many locations. I actually need to go and add them up because there's so many, I can't exactly get the right number, but I want to say at least 25 maybe, yeah, as a rough estimate of how many different places we taught at. So
I
it was
think
a
it was a
busy
lot more than that. I keep forgetting to add Kristine's in, but I think altogether
That's
it might
right.
have been more than that.
Yeah, that's right.
Yeah.
Yeah. And we had a range of teaching settings. We had some private classes of 4 students. We had some jam-packed days of 32 people, which is our absolute maximum with 2 instructors.
Yep.
We had some hospital trainings. We had some trainings with no obstetricians. We had some with several. So we've had a kind of a lot of different groups and different flavors of trainings as we were in different locations around the 2 countries.
Mhm.
One thing that struck me is that in Australia, we had hardly any physicians at all. I think in part because it was our first time there. And what typically happens is the first time we train in an area, it's way more predominantly attended by midwives because they tend to know of what we're doing a little more. And let's just be honest, midwives tend to be the ones attending vaginal breech births and a little bit more open to learning numerically speaking. So, we tend to have a more predominantly midwife audience the first time. And then usually every time we come back to an area, we typically get more and more physicians. It's in part the way birth networks work too, is that the networks that we are in typically are more well connected within the midwifery communities. So they know of our program. Whereas the physicians just have a lag in knowing about our existence, and that typically comes later. So we had a lot more physician uptake in New Zealand because we trained there in 2019. I think that had a lot to do with it.
Okay.
They typically will train and then bring word back to their hospitals. And then the next time around, they bring a few more of their colleagues, and it works that way. So those were some of my first impressions. The difference between the 2 countries is that the makeup of our attendees was quite different.
Yeah, definitely. I was, however, very happy to see an Australian doctor on our live session Saturday night. Dr. Andrew Bissets was on our live session. So,
oh, that's wonderful. He joined you. Yeah, I finished editing the recording, but I haven't had time to watch through the entire thing. I was just going through and doing the quick edit. So I had to skip through most of it. Yeah, that's great that he was here.
It was good. Yeah, I didn't notice it, unfortunately, at first, and I only saw that he was answering questions in the chat later on. I'm like, oh, okay, Andrew, how you? Welcome.
That's great. Yeah.
One of the I'm not sure if you're aware, there are sort of differences with how midwives practice between the 2 countries. Most of our healthcare system between Australia and New Zealand is quite similar, in a lot of ways, but maternity healthcare, it's quite different. So in New Zealand, they operate with a system. You have your hospital shift working midwives, but you also have your self-employed midwives who they're termed LMCs, lead maternity carers. And so they do that continuity of care, of case loading, where, they're looking after the woman antenatally and then attend to birth and then do home postnatal visits. I haven't worked in Australia, but from a lot of what I've heard, there's a lot of New Zealand midwives who have gone there to work, and although they earn better money and they have lower workloads, they have nowhere near the same autonomy. Yeah, so things like sort of have to ask a doctor just to be able to give someone paracetamol type of thing. So yes, so that's probably, I don't know how much that would impact. I would imagine it would impact fairly greatly the amount of sort of influence and power. Power is not the right word, but the amount of influence and advocate.
Power is often the right word.
Right. Okay. Thank you.
Yeah.
That they can, help. And so it wouldn't surprise me that I guess New Zealand midwives would feel like they have perhaps a better chance of trying to have some influence. It's still an uphill battle
It is.
with obstetrics, but fantastic that we're seeing more obstetricians there. I think another thing that's happened, you might have seen it sort of around the world, is that we seem to be seeing, with our newer obstetricians coming in, our millennials coming in, and they are open to doing things differently, and right, and there's we still have some very old school obstetricians, at the top of the hierarchy, but you can kind of get a vibe that some of these younger registrars are keener to see things a little more holistic, perhaps. Or what's your feeling on what's going on out there?
I mean, it is very true that New Zealand midwives have more autonomy of practice. They have fuller scopes of practice. They can do home births and then take their own clients into the hospital and be the person managing them in the hospital. I don't know anywhere that that midwives have that freedom of range of options.
Wow.
I don't know anywhere that's like that. But even in that system, there is still some tension between, in some hospitals and in some areas, there is still some tension between the obstetricians and the midwives. I mean, we had, I'll say this and then I'll shut up and let talk, but we had, there was one hospital whose name escapes me in the Hawke's Bay area that very much bought onto the program, to the extent that they were talking about coming up with money to have me come over and actually supervise a breech service for a while to get it up and running, which I don't see how that would be possible, but it's a great idea. But then there were other hospitals where, in the same region, where midwives told me they had to fight to even get the training in the hospital. The obstetricians were adamant that they didn't want our training to be hosted by the hospital. And we ended up doing it like in a boardroom or something, so it wouldn't appear too medical. But so there's still a really wide range of attitudes, even among the New Zealand obstetricians toward attending vaginal breech births. And I agree with Rixa wholeheartedly. That's our uptake was dramatically better this year than it was 2 years ago on number of obstetricians that were interested. A lot of those were registrars, but a lot of them weren't. A lot of them were consultants. There were a lot of UK based people who were, and a couple from the US actually, who were in consultant roles there. So yeah, I mean, I feel like it's going to, I feel like New Zealand has the opportunity to really broadly accept vaginal breech birth as the norm, probably before anyone else, the way they're going. So
yeah, I think you're absolutely right, and I can certainly see those situations where you've got, this hospital's open to it and that hospital's not. Yeah. And at the end of the day, I think we all know that it really probably comes down often to one person. It's that person that's right at the top, that's typically head of the obstetrics department, and they really are setting the tone. And yeah, and I think we've probably all seen situations where, so because our registrars, have time in different hospitals, and as they do in so many places. And I do remember one time hearing a conversation years ago, but going on with the head of midwifery in a particular hospital with a registrar who was new to that hospital, but they had both worked together in another hospital.
Mhm.
And that other hospital has got the reputation of having the highest level of normal birth in New Zealand. And I remember hearing him making this decision on something, and I think it was to do with an induction. And she's like, would you have done that at the other hospital? He goes, no, I wouldn't. Well, why are you doing it here? Well,
Right.
the consultant told me that's what they want.
Mhm.
Like, come on,
Yeah.
you can advocate, and so the registrars themselves are, kind of pushed in different directions, aren't they? So yeah, but that's a really interesting observation, that you can see that New Zealand is potentially leading the way. Probably not surprising, I guess. Yeah, so what were the things that really surprised you, maybe in a good way or a bad way?
Coming from the US, we tend to look at the midwifery in New Zealand as this amazing thing, because compared to what we have, you have so much autonomy and freedom to kind of follow your woman from home to hospital seamlessly, to remain the care provider, freedom from a lot of the worries about malpractice that we have in the US. And it was interesting to see that the midwives in New Zealand, while recognizing that, also felt that they had so many barriers and obstacles in their own profession. Whereas we see it as something to aspire to, because we're so far behind so many of the things that midwives have in New Zealand.
Yeah, it's sort of depressing. It may, as much change as we feel like you're making, then to go there and see that and realize how much further still we would have to go to get where it needs to be. Yeah. But
I mean, we're still working in the US. Midwives are still felons in about, I don't know, half of all the states. Home birth midwives, they're not, not even legally recognized in about half the states, or, so it's just such a mess, because we don't have consistent regulatory licensure schemes. Every state is different. Every state is it's basically its own fiefdom, has its own rules, own regulations. And so you have 50 different sets of rules and regulations. You don't have a national standard of any sort. And, I'm not going to go on too much about the US, but it's kind of a messy place to practice.
it is. And of course, none of that is in any way, shape, or form evidence-based. Just the concept that the standard of care should be set by individual hospitals is just absurd on the face of it.
Well, and we see that happening. I mean, this is something that's shared with New Zealand and Australia. Again, like you were saying, David, that the hospital culture is so localized, and in the same town, you can have disparate cultures doing totally different things, right?
Yeah,
and
absolutely. Within, say with the LMC, self-employed midwives, when there is a complexity or a potential complexity, in the pregnancy, then the normal thing is to do an obstetric referral and with the local hospital, and you would sit down usually in a threesome, as such, the midwife, who's the LMC, the lead maternity carer, the woman, and any whānau family that she wants to bring with her, support people, and the obstetrician as the consultant. And you as midwives, which obstetrician works on which clinic day, and which one that you want to take your woman to, and which ones you don't want to take your woman to, because even then there's inconsistencies going on decision makings. This one will go, oh, macrosomic, right, let's book for a C-section. This one will go, well, no, we need to allow large dates to clear itself. So there's all, so even then you're still not getting consistencies. And I do recall the head of obstetrics at one particular hospital being quite sort of the midwives really kind of complaining at the lack of consistency, and how every obstetrician's making a different decision based on the same information, and how we do, pigeonhole which woman goes to see which doctor, and it shouldn't be like that way. And her response was, that these are autonomous consultants, and she's not going to tell them how to practice. And you're like,
if they're practicing evidence-based medicine, then they should also all be coming up with something similar in terms of the way they counsel the people they see. And if they don't have the information or the training, there's no excuse not to get it.
yeah. So yeah, I mean, it's a nail on the head. They should all be coming up with pretty much the same answer, because it should be all evidence-based. Yeah.
There's I'm just going to jump in real quick, and I just want to answer one of the questions in the Q&A chat, which I think is pertinent to this discussion too. So Carrie Mapperson from Queenstown said that regarding the commentary on New Zealand having more influence, her impression was that it was more the norm in Canada already. And I think that yeah, I have to dispute that. There is actually only one midwife in the entire country of Canada that has hospital privileges to do vaginal breech births, and that is Betty Ann Davis. And she, who's one of the most experienced breech providers in the world, still has to fight constantly to get privileges at other hospitals, to be able to do the births that she wants to do the way she wants to do them, based on the evidence and the information that she has. So yeah, no, Canada is definitely got a long ways to go.
Yeah.
Where do you how do you sort of compare Canada to the USA and Australia and New Zealand and England, say? Where do they all kind of sit along the spectrum?
Canada's system is similar to New Zealand's in that midwives offer the full range of birth setting, especially the ones, unless you're a shift midwife at a hospital. So if you're a midwife in Canada, you have to offer home, hospital, and birth center if birth centers are available. You have to offer both home and hospital options. And so most midwives will do a mix of home and hospital birth, depending on the local population. Some will do more heavily home birth, more heavily hospital, but you have to support and offer both. That was one of the kind of ways that they structure their midwifery systems, which are very recent. I think the oldest midwifery program was in Ontario, I want to say, maybe in the 90s. Now, Betty Ann Davis and other Canadians, you can correct me if I'm wrong, but so they can seamlessly stay with their clients if the client wants to transport from home to hospital, unless it's something that requires an obstetric level of care. And at that point, I think they have to call in a specialist, but they still can stay with and stay as the woman's midwife if they have to change locations, even if they need more care. So that's really different than the US, which you basically have to drop your woman off at the hospital and hope for the best. Sometimes they'll let the midwife come and just stay in the room, but absolutely no clinical care level at all. You have to abandon all of that and turn it all over to a completely new person as soon as you go into the hospital door. So it's a really good system in a lot of ways, because home birth is integrated into midwifery itself on the most fundamental level. But if you want to do a breech at a hospital in Canada, as a midwife, even though you have hospital privileges to do all your other births, you can't do the breeches in the hospital. You have to get privileges to do breech in the hospital specifically. And like David said, we have one midwife in the entire country who's managed to get privileges at like one hospital. So you either do them at home.
Identify breech is specifically not included.
Well, in their scope of practice, you can do breech as a midwife,
right?
But the hospitals won't let the midwives do it in the hospital.
Right.
And so they're supposed to turn over care to the obstetrician according to the hospital regulations.
Right.
But the problem is a lot of times the midwives are more experienced than the obstetricians, or have the only ones who know how to do like physiologic breech. And they can do them at home, but they kind of a lot of them, like even Betty Ann will occasionally do breeches at home, but she tries to do them in the hospital because she feels that's just a better place for her to be doing them, given her level of training and, you know, politics and a lot of stuff. So you could do them at home, but it's kind of like, but then if you want to do them in the hospital, you're supposed to, the policies of the hospital make you transport your and give it over to the obstetrician, even though your scope of practice regulations from your midwifery board let you do breeches. It's a really weird kind of system. So we haven't sorted out a good thing. And despite the fact that the SOGC guidelines, when they were revised and then updated again, just 2 or 3 years ago, were very strongly supportive of vaginal breech birth as an option. Despite that, the vaginal breech birth rate in Canada has gone up maybe like 1/10 of a percentage point. I mean, something ridiculously small, very, you know, hardly, maybe 1%, maybe. I saw data on it a few years ago. I just can't quote it, but the point being, it's hardly shifted at all, despite really strong support from the national leadership. But on the ground, not a lot is happening, and that's frustrating.
Yeah.
It is.
And what about the acceptance of the education? Is it still just midwifery led everywhere pretty much apart from New Zealand? Is that sort of what your general impression is? That you're not seeing the doctors coming through wanting to upskill themselves in that area?
I mean, I think that it's changing. I think that it's changing more and more in the US. I mean, we've trained 5 major tertiary care level, mostly teaching hospitals in the last year. And we have several more on tap for this year already. And honestly, if you had told me that I would be teaching residents and attendings in hospital that you would call registrars and consultants, but we call them residents and attendings. If you had told me that I would be teaching residents and attendings in hospitals in the United States, you know, in 2019 when we started, but I would be doing that by 2022, I would have told you were on drugs. It's just like,
Wow. That's so exciting. So you're starting to see some momentum. It might be that case if it's a real case of momentum, isn't it? You know, it's just starting to see those changes along the way. We've got a few questions coming in, so let's just have a little look through. So comment from Terry: maternity care is very regulated in Australia, even private practice legally need collaboration with doctors for any kind of pathway in Australia. Interesting. Okay. Nancy, oh, that's a shame. I'm going to be in Ontario for a month next year, is hoping to attend some training again there. Oh, well, maybe you guys may be doing some training in Canada.
We are, yes.
We are this summer. I don't know about, I'm not sure about next summer, but we're definitely there this summer.
Yeah.
Okay. Well, yeah. So it'll be a case of just going on to the website, and your trainings are all up there, aren't they? Yeah. Okay.
Try to keep them up. There's usually a lot more trainings in process than are on the website, but yeah, we try to.
We have several, I think 5 or 6 now announced on the website in Canada. So we have some in Eastern Canada, in mostly Ontario, but 1 in Nova Scotia, also 2 in Alberta, working on some in British Columbia. So stay tuned. Yep. And Betty Ann Davis will be joining us for several of them. She's working on her schedule, so some of them aren't yet officially announced, but as soon as she joins us, we'll add her to the flyers and to the website. So that'll be exciting.
Cool. What else have we got here? Hello all, I'm Nancy and a birth keeper from Massachusetts. And thank you for all that you're doing. Yeah, so you guys are just absolutely leading the way. So we all appreciate that. And Kerry Mabison, hopefully the changes in New Zealand from separate DHBs to the Health New Zealand to Whataora will enable more consistent guidelines countrywide, like the UK, rather than hospital influence policy. Yes, so there is a big change happening in the New Zealand health system, that it has all been run by what is called DHBs, district health boards, which have been, you know, regional places all around New Zealand that run everything within that region, and that is changing to a nationwide management. And it's interesting because it used to be nationwide, and then everyone's like, no, we need individual regions need to be able to manage themselves. But of course, we had that for a while, and you go, yeah, that's not working, so it's going back. But anyway, it's always cyclic, isn't it, these things? So it will be interesting. But certainly, you know, the UK is very strong, isn't it, with its nice guidelines, and that, you know, every hospital is expected to follow those. And yeah, so there is, well, it will be interesting. And Kerry's also meant, well, so are the midwives. They're supposed to attend births in just birth centres, if not at home. I'm not sure what that question was relating to. Are we talking about Canada?
I'm not sure what she's referring to. There aren't a lot of birth centers in Canada. It depends on the province. Some of them do, some of them don't have birth centers, but they don't really, I don't think they really do breaches in the birth centers.
Or maybe she was talking about, oh, here we go. I heard David mention that in a recent live session about teaching whole hospitals in the USA. And that makes me feel that the USA is further ahead on the change than New Zealand. I could never have imagined that happening in the USA. Yeah,
there was at least a few that trained most of their hospital staff, or a great amount of them, in New Zealand. David, you did several of those, right?
Yeah. I did. So it's happening both places. The staff typically in the hospitals that we go into, I mean, sometimes it's the staff themselves that want us to come in. Sometimes it's driven by the people that are being trained, the residents who want that information. So the cultures are different, and depending on the nature of the hospital, they do all tend to be, I think, with one exception, or is that not right? No, I think they've all been teaching hospitals, so I'll have to say that is an accurate statement. But yeah, I don't know where I was going with that. Anyway.
So Terry's got a comment here. Breech birth in Australia is the same as Canada, as obstetric led in the hospital, even if the midwife may be more experienced than the OB. Considered outside the guidelines for private midwives. Therefore, women need to sign documents, a record of understanding for care outside the guidelines, hoops to jump through to remain at home.
And I did notice that in Australia, most of the midwives who came were like, we just can't do breaches at home. And, you know, the ones who said, well, technically you maybe can, you know, but you have to do all these things. If we do, we're going to get written up by our board of whatever it's called. I don't know if it's the ACM or with whatever oversight board it has, they're going to get into trouble. They pretty much know.
College of Midwives,
yeah. They just know that if they do, they're going to get into trouble. Even if the woman has signed all the forms and wants this, and they risk, you know, it risks their livelihood by supporting that, even if they're doing all the things they should by signing all the forms and jumping through the hoops. I also spent time with a friend of mine. I won't name her, but if you know Australia, it's one of the people who went through some massive legal battles because she supported breech and twins and other things in a home setting, and eventually lost her profession, you know, had to go to some big court cases, and just went through a massive amount of trauma getting persecuted for supporting women's choices. and had to give up midwifery. And it's so frustrating to see, someone who's giving her heart and soul and who gets punished for it, and then has to eventually leave the profession, and can never return to it. So it's frustrating to see that climate. At least in New Zealand, midwives know that they can support breaches, and if they, there might be some local people who hassle them, but they're not going to lose their registration. The same way that midwife, not the same way midwives in Australia worry about it. I guess I should say I wasn't sensing that. It's more like maybe in New Zealand they're hesitant to support it if they don't feel well skilled, but they don't at least feel like they risk potentially losing their job the same way. That's my impression. I could be wrong.
Yeah, your influence of the fact that you were in New Zealand in 2019 and back again, I think that is helping to give legitimacy to considering breach. And I do know of there was a case, it was some time ago, but there was a case of a poor outcome with a breach where the midwife was actually there was two cases I'm thinking of, was absolutely roped over the coals, and it was dreadful what she went through, even with the clients themselves supporting her and saying, we consented to this. This is what we wanted.
Yes.
Right? And she did explain this, and even then with the clients, there was one case where the client absolutely 100% had the midwife's back and the midwife was still roped over the coals. And there was another situation where it was the midwife and her colleagues had spent a lot of time in conversations with the woman, really telling her that home birth was not the right situation for her with that, particularly where she was located. It was quite remote. And the woman was absolutely insistent, and they got her to sign various different things, and they did everything in their power to get her to try and consent to going to a hospital. She didn't. It was not a good outcome. And then she completely flipped around and wanted the midwife crucified. So but both of those happened before 2019.
Yeah.
I don't know, 10 years ago and 5 years ago or something roughly. And so you guys coming into the country, this adds that whole legitimacy to it, that it's not so radical, and it's not, it's gives that credibility, I guess. So it's very helpful. So Terry, is in Australia, we are not to attend a known breach at home. If an undiagnosed until the labour, then they must be transferred. Okay. I wonder what happens in Canada if maybe they are not allowed to do breech births in the hospital, but look, it's undiagnosed. Don't know.
Don't let the consultants know.
Yeah. Oh dear. Yeah. We get in trouble. APRA is who you get in trouble with, not ACM. Oh, okay, in Australia. Okay, so that'll be the governing board that we would, council kind of equivalent. Okay, thank you.
Yeah, the regulatory bodies. Cherry just chimed in. Yeah.
Okay. In New Zealand, there is still a lot of fear of the HTC, but maybe we feel more empowered to fight the system a little due to our history of autonomy. Yeah, I think you're right. The HTC is the Health and Disability Commission. So yeah, in New Zealand, it's not possible to sue any health professional. And there's a regulatory body called the ACC, and that's, anyway, it all kind of gets involved in there. But it is still very possible for any health professional to find themselves in hot water. And you are always in that kind of guilty until you prove yourself innocent
Yeah.
definitely
No,
comes with that slant with the Health and Disability Commission.
yeah, it is. It was a little striking to me, the doctors, I won't say obstetricians, the doctors that we had that in Australia that came to the workshops. I think, unless I believe I'm correct in saying all of the ones who were actually obstetricians working in hospitals did not intend to do breech and did not think they could get away with doing breeches in their hospital, but wanted the skills in case of an emergency. The exceptions to that were the general practice doctors that worked in remote areas in Australia. And they said, we don't have options. We have to do them there if we have them. So, so you have that as well. And you have to provide training for those people. Why are you holding them to a different standard from the rest of the people? So, I don't
know. And that point that you made, David, brings up such an interesting observation, is that even the doctors we're training by and large feel that they're so constrained and have almost no autonomy to do breech either. And it's kind of like,
absolutely,
it's a little bit stunning that the obstetricians themselves feel like they can't do it, aren't allowed to, or get into trouble. And if they can't, I mean, it's a ridiculous system where, on the hierarchy, as you traditionally look at it, obstetricians are in the old-fashioned way of thinking, right? The doctors are kind of the top dogs. And if the top dogs can't even do this, and feel that they'll get into trouble,
well, some of them are a lot more top than others.
Yeah, it's a bit of a crazy making system. I think it's understandable where midwives feel it, that constrained in maybe some of their autonomy and choices, in part because of the historic sexism of the profession being seen as a sub-profession of medicine, like something less than or lower than. Yeah. But it's another thing when you're looking at medicine and still seeing this massive constraint among medical doctors. That might be a nice thing to talk about, and what some of the interactions that we've had with the ones who've attended our training and what they express to be their obstacles that they're facing.
Yeah, there was I'll never forget this one that I had, and I won't identify them, so I will stay away from naming hospitals and whatnot. But this person was one of two obstetricians that came to an out-of-hospital training, and I'll just say on the west coast of the US. And after the training, I went out to dinner with the two obstetricians just to chat and to try to scope out what the situation was like. And one of them had been instrumental in having me come to that city in the first place. And the other one of the two obstetricians was a maternal fetal medicine specialist. And she was the head of the program at a major academic medical center teaching hospital. The head of the program. And she told me during dinner that she paid for the training out of her pocket, because they get money to go to these different trainings. You have to put down what your training is and all this stuff, and then they pay for it. But she told me that she paid for the whole thing out of her pocket because she didn't want anyone in her hospital to know that she took vaginal breech birth training. Now that shows you how much fear this was the head of the program in the hospital. That shows you how much fear there is in so many hospitals.
And it's baffling that you have to hide the fact that you're getting training in an obstetric skill.
Yeah, absolutely.
Right?
Yeah.
Gosh, isn't that shocking?
Actually, no, it's not shocking to me.
No, not shocking. But when she's head of the program,
it really is there.
Yeah, head of the program is still, it's still so ingrained. What about England, with its nice guidelines and whatnot? What's your reception over there?
We have not trained in England yet. We had a lot of inquiries, and then COVID hit, and so I think it'll come, but they also have Sean Walker and her colleagues, and she kind of predominates in that area because that's where she's from. So they tend to often book Sean for their breech study days. So I'm not as familiar with the system, having not been able to go over and train there yet.
Right. Be interesting. Let's have a look at some of these other comments. Then Margaret says, then who is in charge? Obviously, the medico-legal team and insurance body for that maternal fetal medicine doctor who couldn't have the influence.
Right.
You'd say that's probably what it is. Yeah.
The people with the power are the people who are in charge, and you ultimately have to bring enough power to bear on them, enough pressure to bear on them, so that the consequences of not doing it, of not embracing it, are worse than the consequences of embracing it.
Yeah. At the end of the day, that's, Any recommendation for student midwives hoping to practice in the US who are interested in breech birth? To my knowledge, CPMs are able to attend breech in home, depending on specific state regulations. Do you know of any states in the US where CNMs can attend breech outside of or in the hospital? My understanding is that the degree of autonomy is very state dependent, but wasn't sure about breech. Everett Oxrider, North Carolina native, current student in Guatemala.
It's absolutely correct. Every state has different regulations. And so whether a CNM can do a breech at home depends on the amount of autonomy that state allows her. In some states, they're completely autonomous. They don't need physician cooperation or supervision or collaboration agreements. And so in those states, they can do breech births or whatever else they feel is acceptable to them and their clients. And then in others, it'll just depend. So I don't have a comprehensive list of states as far as the CNM regulations. Usually the CNM regulations don't mention breech specifically. It's more the obligation to have physician collaboration or not that would then restrict the details of what they do within their practice. But there certainly are a lot of states where CNMs could do breech births. It's, for sure. I just don't know which ones are the better states for that or not.
Yeah, I certainly there are places where CPMs, there are plenty of states where CPMs have more autonomy and more power to practice the way they want to than CNMs in that same state. And a lot of that's because the CNMs often, but not always, are not independent practitioners. They have to have a supervising physician. And you end up with places like North Carolina, which you said you were from, Everett. That's in North Carolina, CNMs can do home birth. They can do breech out of hospital, in hospital. No, probably not in hospital because there aren't any hospitals that do it, but they can do it out of hospital as long as they have a supervising physician that will sign off on that. And there's almost no almost no obstetricians in the state who will supervise CNMs now. I can think of one or two.
Yeah, it's basically a restraint of trade because it creates a stranglehold in the profession.
Yep.
You have to have a physician collaboration, but physicians are not obliged to sign or even consider it. So by fiat, you completely restrict a person's ability to practice their profession.
And then
that need to have somebody.
Sorry.
That need to have somebody supervise and sign off. I imagine that person, the doctor, is taking some level of legal responsibility for the outcome. Correct. So that would probably be right. So that's probably they're saying, well, I'm not going to sign off on what you're going to do because I don't want to get in trouble that you stuff it up.
Especially when I don't know how to do it.
Yeah. And it's the supervising, and that when they say it's a supervising of physician, is that person needs to be like physically in the room, like actually hands-on, or is that just a paperwork kind of thing?
Depends on the state. Regulations are different. In North Carolina, if you're a supervising physician, you have to have monthly meetings with your people. You have to do chart reviews. There has to be a collaboration agreement, and all of the things that the person you're supervising has to refer to you for are spelled out in that agreement. So if they don't do that, then they get in trouble. It's very, very, very distasteful.
Okay, and New Zealand has something perhaps similar along the lines, which is called Section 88, which is a set of referral guidelines. So these are basically all the things that need to be referred from a primary care LMC to a secondary care obstetrician. And so there's like a list of things that need there's like different levels of referral. So there can be referral where it's actually a handover. And in fact, really every time there's a cesarean section, that is a moment in time where that woman's care is handed over from primary to secondary care. And then after the cesarean, at some point, that doctor will write in a note that he's handed back care to the LMC. But it does make it pretty straightforward that there's those guidelines are pretty comprehensive. There's pages and pages of them, so they do sort of cover most things that there would be a poor excuse that you haven't followed the guidelines. Okay, who else? So we've got some comments here. So we are going to be winding this up soon. It's just been so interesting just having this very relaxed, casual chat today, and getting you guys impressions and feedback. So if anybody does have any other final questions for Rixa or David, please put them up now. We'll make sure that we get through those. So Terry has commented, ACM, that's the Australian College of Midwives, is just a professional organisation for midwives, and APRA is the regulatory body, which we covered off before. Fantastic. And a little thank you there from Everett. And Charlotte, another barrier is one's ego. Even if there is a trained midwife in a rural community that knows how to safely attend and to be part of a physiological breech birth, the fact that a local doctor is not willing to do one or doesn't know how to do one and will never admit that fact, and then her skills as a midwife are not accepted because the doctor, I totally, yes, I think that's a global issue, is it not?
It is a global issue, no question.
Yeah, absolutely. I know of one senior consulting obstetrician at a hospital I used to do a lot of births at, where a woman walked in the door well into labor, and no one breech, and she had a history, I think 1 or 2 vaginal births before, and the doctor just point blank said, we're not, it's not happening. I don't have the skills and I'm not going to be doing it. You're going to section. Even though there were midwives on the birthing suite at the time who were happy to look after her, it was outside their call at that point, because that's a referral. That would be part of a referral guideline, malposition baby. So that needs a referral. And but
well,
even
I would counter that it's a malposition, but
right.
Well,
It's a different position.
yes.
Well, the midwife educator that we worked with in Lower Hutt was reminding us, she said it's a referral, meaning you might want to refer to somebody, but you don't have to transfer your care. You just have to suggest, you just have to offer the referral, and they can decline.
Correct.
There's room to work within that. You have space for some flex. It's not like you have to give up care necessarily.
Yes, and I think that part of that issue is that no, you definitely don't have to give up care. I mean, there are certain times where there is a full transfer of care, and they're pretty serious and they're pretty rare. But usually the LMC, which is often a midwife, is still well involved. But there is a fear, I think, of the woman herself later turning on you. You know, so she agreed at the time, but then if things go pear-shaped or, you know, don't pan out as she had hoped, then there's always that need to find someone to blame. So I think that still can be a bit of an undercurrent. And when will you be back in New Zealand? It's been quite a good New Zealand Australia focus today, but interesting for our international audiences. But that's what we're talking about, because you guys have just done New Zealand and Australia. I feel like there's a bit of fire in me now, and that I can use your articles and evidence to somewhat influence local OBs here with breech birth planning. But I feel we have so far to go. So when will you be back in New Zealand? And
that's a great question. I would say for sure in 3 years from when we last came, so a few months ago, maybe 2 years from then, if we get enough interest soon enough, because we have to start planning probably more than a year in advance, because our schedule fills up. We're already booking through October, November next year, right? So if we have a massive amount of interest, we could come in late 2024-ish. That's probably the earliest we'd be back, and then most likely 2025 sometime is my guess. It all depends on how much interest we have, but if we're going to go over, we have to get quite a few places interested, because it costs a lot to send the whole team that far away for that long, and we have to make sure that we have enough teaching once we're over there. So part of the reason to wait is that it can accumulate more sites who are interested. It's a shame we can't just pop over, right? Otherwise we'd just hop on over and teach a few classes and hop back. But
hey, David, I'm curious, you know, how are you seen by your obstetric colleagues? Right? You know, do they just see you as this complete, you know, rebel without a cause kind of thing? I mean,
I am seen by the majority of my colleagues as a rebel with or without a cause. But I'm in other situations and by perfectly respected people in positions of power in different hospitals, I'm, you know, seen as an obstetrician who has something to offer, and not as a kook, as maybe brave. I don't know. I don't think there's too many doctors practicing in the US that aren't familiar with the amount of pressure and peer pressure that there is. So if someone's willing to be open to the evidence on term breech, it's not going to shock them that most of their colleagues are totally opposed to the message and the messengers.
Yeah, I mean, you're quite an inspiration for them, you know. I would imagine, to just go, well, heck, if he can do it, you know, if he can lead the way, why can't I? I mean,
for the meek, I'll tell you.
Yeah, I remember there's some in South America, there's a couple of well, there's more than a couple, but there's two in particular I was thinking of, Ricardo Jones and another colleague, who are very strongly homeopathic obstetricians, that they use homeopathy as part of, you know, what they do, and they've both got amazing, you know, outcome statistics. You know, it's mind-blowing, and they're in countries where obstetrics is paid for by insurance, so it tends to have much higher rates of intervention and C-section. And yeah, and they do it's hard, awkward, you know. It's people, not awkward's maybe not the right word, but you know, they know that they're rebels, and they know that they're disrespected by people who don't, you know, are more medicalized obstetricians. But what you're almost preaching to the converted a little bit with a lot of midwives, which is fantastic. Like they want it, but with the obstetricians, you know, you're so important, I guess, is what I'm trying to say. What you're doing, and the fact that you're sitting in that position saying, guys, colleagues, look at the evidence.
I mean, I'm not terribly concerned about whether or not I'm respected by the broad obstetric community. I have to respect myself, and I can't do other than what I think is right. So they can disrespect me all they want. That doesn't really impact my life all that much.
I love it. And that's why you can do what you're doing, because you're going, well, I don't actually care what you think about me. So I'm just going to do what's right. I love it. The epitome of rebel. And
Can I share a quick thought?
yes.
You know, David, when you were talking about the maternal fetal medicine specialist who was so worried that people would find out she was getting training on an obstetric topic, that she had to hide it from everybody. I think that there's a lot more physicians who actually would be interested or supportive, or at least open-minded and curious, but they see all their peers acting that same way around them, and they don't dare say anything. And I think that we have to start talking about it and being open and not ashamed about it, in the same way that we finally started talking about like sexual assault and you know, having these movements where all of a sudden this used to be something that was so shameful. You thought you were the only one, you know, that ever went through this. You wouldn't dare talk about it. And all of a sudden everybody's talking about it, and you realize, oh, this is something that a lot of people around me share. I really think it's probably the same way among physicians, and we have to get enough people just starting to talk and not being ashamed and just being like, I think this is great. Take a look, you know, and then maybe they'll realize that maybe a quarter of their colleagues at the hospital actually might be willing to be open-minded, because I think it's the peer censure that is one of the hugest stifling factors. Absolutely. Either anticipated or actual, in physicians feeling like they can do this because they just know they're going to get ripped to shreds by all the people who don't think it's a good idea. But if you get enough people willing to just say, oh yeah, I actually think this is a good idea to learn these skills, then you'll reach a tipping point where all of a sudden it's not shameful anymore. And you can just be like,
it will be shameful if you're not. It's almost like a wokeness needs to come into it, of saying, oh my God, what do you mean you're not allowing that woman to have a breech, or not allowing her to have a breech? Like, you can't do that, you know. That you're right, it's that tipping point. And we have witnessed incredibly rapid tipping points on cultures, you know, on cultural norms, and that just in the last decade, right? You know, where things that have gone from almost shameful, you know, to agree to it, it's shameful to disagree, it's shameful to agree. It's like things have changed so quickly. Yeah, and you've probably really hit the nail on the head there, that it's people are going to have.
Absolutely.
Do we want to make it shameful? Well, if that's what it takes, you know, are you ashamed that you're an obstetrician who's not confident at doing breech? You should be ashamed.
Yeah.
Well, they haven't had the opportunity to learn because of a systemic failure that's been gone on for 2 decades. But that's no excuse for not learning now, because we're making it available. I mean, I've been saying for well over a decade now that what obstetrics in the United States needs is a Me Too movement. That's exactly what we need, both for its clientele and for themselves. They need a Me Too movement. They need an honest conversation.
And that it needs to probably be quite woman-led. You know, I mean, it's women that got partners into the birthing room. You know, it was them putting their foot down. And
Mhm.
yeah, okay, I'll run through we're going over time, so I'll run through the last of these commentaries here. So when you come back to Australia, please consider the Sunshine Coast. We've already got 15 people wanting to attend. I am the only one in this region who has attended this learning, struggling to have support here, have to ask midwives from outside my area to attend me. So the Sunshine Coast is north of Brisbane.
Okay.
So yeah, lovely, that's cool. I know Nancy is saying I know of 4 breech-free births since spring. What is your opinion of this option if you are seeing or hearing about it, free birthing? I mean, I'm aware that in Australia, because home birthing is practically illegal, I don't know, like that there has been a growing movement of free birthing, which is obviously pretty concerning. What's your commentary around that?
So those of you who know my academic background and my personal background, so my dissertation was about unassisted birth. That was my very first academic focus within the childbirth world. I had my first unassisted on purpose. Okay, so that's my background. What I would say with breech is that when you need help with a breech birth, you need help in about, you have a few minutes to fix the problem or your baby will die when a baby really gets into trouble. And that's the difficult part, is that most breech births go just fine and some don't. And if you need help, you don't have time to do anything else. Calling 911 is not going to help. Transferring to a hospital is probably going to be too late. So the tricky thing with free birth, I get it, because I am a free birther myself. I did that with my first pregnancy and it was wonderful. But I am concerned.
Can I ask the question?
It's a special skill. Oh, sorry, go ahead.
So the devil's advocate in there.
Yeah.
Were you doing that from the perspective that you just felt like it was the only way to be able to have that home birth that you wanted? Or, you know, like I think that sometimes the women are free birthing, not because they don't want an attendant, but because they can't get the birth they want and an attendant.
Oh, totally.
Yeah.
So,
okay.
So with my birth, it was, so I think that women come to free birth in, if I can make 2 big umbrellas. One is that they're pulled to it. They're drawn towards it because they really believe in the philosophy. They really want that for their birth. It's just, they want it. And others are pushed into it because of lack of other choices, you know, previous trauma, no good midwifery options, maybe previous trauma at a home birth, you know, fear of the hospital, fear of intervention, very real fear of, you know, too many C-sections. So I think there's kind of two main factors. One is they themselves are seeking it, and one is that they have no other options and they're basically refugees. For me, it was mostly I was drawn to it. There was a home birth midwife that I was actually working with at the time, very skilled. She was pretty much the only one in my area, about an hour and a half away, but kind of far, you know, farther than I would have liked. But I just didn't want her in my birth room, even though I was working with her. Just wasn't somebody I wanted at my labor. And I just strongly felt that. And I was also feeling kind of in a real intuitive sense, like I really just wanted to have this baby unassisted. And it's so weird because I'm normally like this ultra logical person, but this was a very much like intuitive led process. And it's not my normal modus operandi, but it was for this pregnancy. It was great. So mine was less trauma, lack of options, fear, and it was more, I want this. This is what I need.
It's your mummy intuition going,
absolutely
the right
yeah.
thing for my baby.
And I don't say the things I said about breech free birth to try to be a fearmonger, because people get so upset. Oh, you're just scared. You're promoting fear. And I'm like, no. You know, it's tough because we hear about the breech free birth deaths that get reported to us, kind of like that we know of, like because we're in the same city or somebody had one, or, you know, people don't talk about them very much publicly. And it's just frustrating to see births where if they had had a skilled provider present, it might have been a very different birth. And it's not because I'm trying to promote birth as being fearful or trying to, you know, scare people. It's just the reality. When breeches get stuck, they get really stuck, and you got to get them out skillfully and quickly. And that's my hesitation. It's like, you don't know until the very last few minutes if you're going to need that really skilled and sometimes massive amount of intervention. We debriefed a birth just a few nights ago on a live session with a baby that had undiagnosed Down syndrome. And this baby got really, really stuck, had very poor tone, which was then explained by the Downs diagnosis afterwards, and required extensive maneuvers. And, you know, it's because of a midwife who's trained with us multiple times. She got the baby out, and the baby did wonderfully. But, you know, it's frustrating to me that women have to turn to that because their midwives are not allowed to attend. There's no other options. There's no obstetricians willing. You know, I don't denigrate anybody's choice to have a free birth. Again, I'm coming from that world myself, but with breech, it's particularly vital that we don't restrict options on the care provider's end or on the women's end, because, you know, we don't want to have unnecessary free births where women would have liked to have a provider but couldn't. Yeah. That to me is a tragedy. If you want to have free birth and you do it, I think that's wonderful. But there's so many women who honestly would like to have an experienced provider, but they can't. And that to me is the real tragedy of the story, is when they want it and they can't. So, yeah, sorry.
Absolutely.
No, I went on a little.
No, fascinating. Absolutely. This may be off topic, but do you find an increase of women seeking pregnancies and unassisted birth since COVID?
Yes, dramatically. A lot of people did not want to go into the hospital during COVID. They didn't want to have, not have access and to their control of the process. They didn't want to be told who could and could not be at their birth. They didn't, you know, there's just a whole host of things. But I think there's been a dramatic increase, probably 100 to 200% increase in, I mean, that's a very small number we're starting with as a percentage of the population, but I think it is dramatically higher since COVID than it was prior to COVID.
Yeah, were you talking about home birth generally or free birth specifically in your response, David?
I'm probably talking about home birth. You're right. I'm talking about.
I think that question was around just generally.
Just home birth. I wasn't sure which question it was about. Yeah. Did you have something you wanted to add about unassisted birth, David? I know I took a while to answer.
No, that's fine. You've had one. I haven't. So I like to hearing your take on it. I think that number one, there's a lot of things that are sort of at cross purposes when you start talking about free births. I think that number one, the bottom line is that anyone who, I mean, I can get cancer and I don't have to go to a hospital and have surgery or chemotherapy. I can decide, I have that autonomy to decide what I want to do. And the same thing is true if you're a woman and you are pregnant. I think you have the autonomy to decide what you want to do about that pregnancy and with that pregnancy and how you want how you want to deliver that baby. I do think that people who are drawn toward free births, in my experience interacting with them, and I interact with quite a few, they are very much wanting to control their situation. They want to keep their power over how this goes. And, you know, there are plenty of home birth midwives who, for a variety of reasons, including how the system operates and, you know, the outcomes that they get and all of these different things, practice in a more medical mode than a lot of people would like to, you know. The flip side of that is, I think that people who want to free birth absolutely have the right to do that. They also need to have a sense of what the data looks like, what the dangers are, I mean, there's significantly higher losses in free births. We know that. We don't have great data on it, but we know there are significantly high, and especially in breaches. And I think that people who are strongly drawn to free birth should get educated. They should get a skill set, because often something that is just a minor assistance with a baby transitioning to air breathing, if you don't know what to look for and don't know what to do, you can have a perfectly good birth and still end up losing the baby. I think that there is some level of magical thinking that people adopt and automatically assume that everything is fine and is going to be fine. And I think that they also need to be prepared to accept the consequences of their decisions, if they happen to be bad ones or not. So I am not anti-free birth in any way, shape, or form. I think some people, just by nature of their amount of information and their confidence level and their fear level, are in better position to free birth than other people. And that's not my choice. It's not my decision to make. So yeah, I absolutely support, just like I support a woman's right to or any person's right to do anything with their body, or medically or not. It would be inconsistent not to support that, and I do support it. And they're wonderful. I have lots of friends who have had really wonderful free births, and that's totally, and that's awesome. I've also seen last year, was it last year? I mean, I know of 2 home birth breaches that didn't make it right here in my community in 1 year, and that's a lot in a community of this size. So yeah, so I absolutely support it, but people need to be realistic and prepared.
And I guess that's almost like just, putting it down to it's informed consent. You understand these are the consequences. These are you're agreeing to do something, that you're choosing to do something, and you understand it. So what you say, get educated, have some of those basic skills there that might make a significant difference to the final outcome.
But who are you giving that consent to? If you're
I
free
mean,
birth,
no, yourself, I guess, yeah. I'm involved with a volunteer Facebook forum called Ask the Maternity Gurus, where there's a bunch of us around the world that basically sort of give some free advice on women who are really struggling to get advice on things. And we certainly have got a lot of situations where women are feeling railroaded into something, and they have really no consent going on, because that nobody's explained anything to them, so isn't it? It's just about, it's those sort of, you're not consenting to somebody, but you are appreciating your full spectrum, and you've got the information that you need. So let's just run through the rest of these. And in Australia, the ACM have written consultation and referral guidelines, which cover the requirement for referral to ONG review or a change of care. It's in 3 tiers. And this is also to guides to legal decision making, as in quoting, this is outside the guidelines, therefore we need to transfer your care. Women can decline, but we then need to ask the woman to do a record of understanding. Midwives feel not supported to support women outside the guidelines. Yeah, I think that's a bit of a universal comment. And again from Terry, we've got, thank you for driving this sharing of evidence-based knowledge, which has always been always a variation of normal. That's right. And as you say, David, it's not malposition, it's a different position. Even just that single word, right? Yeah. Wonderful to see this being priorities. Thank you to all of you. My closest referring base hospital in New Zealand is run by 2 American OBs and 2 other North American consultants. Wow, we've got a lot of immigration going on here. But it was disappointed to hear that the Breech Without Borders workshop in that city was cancelled, not well subscribed. But I hope that even one of them would have attended your course. Yeah. We've got a yes from Nancy. That must have been a while ago. Home birth is not illegal in Australia. Okay. There's certainly been commentary across the ditch, as we call it down here, the Tasman Sea, where there's a perception that it is illegal or that the women themselves feel not very supported by the system. It's probably to say it that way. Nancy says no, thank you. Home birth is not illegal in Australia. Here's another one. With a private practicing midwife or through a hospital home birth program if it is available and a woman fits the criteria, but there's a lot of regulations. Okay. So it's a lot of so it sounds like it has to be pre-approved. Rise of free birthing in Terry's area too, in fact, impacting numbers of clients for private midwife bookings. Wow. So their ability to caseload has gone down a little bit because so many are free birthing. Wow. That's obviously a lot of pressure for them to feel like they can't get what they want with the system. I am fascinated by Rix's commentary on birth and free birth, as the argument I used with my OB recently is that breech is the same as shoulder dystocia in terms of needing a trained attendant who knows how to assess in a timely manner and provide emergency skills and maneuvers. And the OBs know we're all trained in these skills in the same way. Yeah, well, it's a good argument. You know, just as you should know how to deal with a shoulder dystocia, it's okay. Good point. I like that. Kerry Mabson, I'm fascinated by Rix's commentary and breech first. Oh yes, we've done that, sorry. Yes, and they are looking to take responsibility for their own decision making because this is woman free birthing, I'm thinking, that have to almost fight for a true natural birth. Even with most midwives, it's just something I am seeing more and more. I am a CBE and a labour support doula, and CBE is a childbirth educator, and I want to help women who are choosing this route to understand what they are taking on. It's all risk management, right? In the hospital, birth centre, and home. Message from Kerry Rixa. I've recently read your birth plan on Stand and Deliver and love it. And do you want to just explain, Rixa, about that and how someone can read that?
Yeah, if you hop to my blog called Stand and Deliver, if you search Rixa Stand and Deliver, you'll find it. It's an old birth plan. You can search in the archives. I sat down when I was pregnant with baby number 2 and I was like, if I had to write a birth plan, what would mine say? So I had loads of fun writing it. I think you'll enjoy it. I have the short version, the medium short version, and the hospital version, and they're all kind of cheeky and a lot of fun. So that's what she's referring to.
Oh, I think everyone's going to be looking that one out of curiosity. And Nancy, thank you for all your thoughtful responses and time given to the questions. Re-informed consent. The New Zealand Obstetric Referral Guidelines state that informed consent includes the right to accept or decline care and intervention. Oh, absolutely. Nothing should be occurring without consent to decline it as well. But yeah, it's it can certainly be delivered in lots of different ways.
That is also the language that Ranscog uses, which means that applies as far as the professional organizations are concerned to both New Zealand and Australia.
Yes. Yeah, it is. A New Zealand guideline, the woman has a right to make informed decisions on all aspects of her care, including the right to decline. Yes, I think we've done that. Yeah, absolutely. People have the right to decline. But it's not always a comfortable right. And they can be feeling quite pressured. And I've certainly seen situations where women, you'd all have seen it, have really tried to advocate for themselves, midwives sort of backing them up and advocating, and they really are left with an impression that the obstetrician typically does not agree with their decision and is not supportive of their decision. And it's just kind of slathering the guilt, and I think we suffer in this area so much of throwing guilt onto mothers with the consequences of their decision. It's quite horrific. When you talked about David, where somebody discovers that they have cancer and they have the right to decline that treatment, that's only affecting them, that's their decision, it's all about them. But we have a baby on board, and that slathering has gone on since forever, isn't it?
It has, but at least in the United States, federal case law is very clear that the woman's right to body autonomy trumps the fetuses in all cases. So, it becomes a different thing once there's a baby, once it's born. When it's still in utero, the woman is absolutely 100%, according to U.S. federal case law, is absolutely 100% in charge of what is or is not done to her body in the service of birth.
I think that would be probably the case in a lot of Western countries. You'd know more about the legislation than I would, but there's this undercurrent, isn't it, of slathering of guilt that sort of goes on there. Even
it's more than an undercurrent.
Yeah,
it's absolute. I mean, in the U.S., women are routinely referred to child protective services if they're going against obstetrical guidelines or obstetrical opinions in their care. Women not uncommonly have all of their children taken away from them for an investigation because of their choices during one particular birth. I mean, boy, that is a slippery slope. Either they have autonomy and control over their body, or they don't. And when you try to nuance it out, regardless of what the outcomes look like, when you try to nuance it, you are taking away their power, their right to self-determination.
Yeah. Well, we will wind this up now. We have gone well over time, but it's been just so interesting and so nice to everybody to sort of be able to put in their comments and just have a general chat about it. I guess, do you want to both conclude and your sort of takeaways or any final commentary that you would like to add?
I wanted to say that if there are people interested in having us come train, whether it's coming back to New Zealand, Australia, wherever, you can submit a form on our website that gets you in our system. Even if it's not for another year or two, that way we know who's interested where, and then when we start making plans to come back to certain areas, we can get back in touch with you, and we know that you want us to come to the Sunshine Coast or to the Gold Coast or wherever it might be. So head on over to our website. It's the How to Book page. And there's a little brief application that you fill out with your contact information and where you are, and we'll get you in our system, and then we'll know who's interested. So beyond that, I just want to say thanks for listening and for letting us talk about our time and for taking some time out of your day to come.
David, any final words from you?
Just one thing that we paid, I think, short shrift to too often, and it, it's because we are overworked, and there's way more to do than we can all do. But part of our effort is to collect the data on vaginal births from all of the people who have trained with us. Part of it, and a very important part of what we're doing, is needing to prove that what we do works and that the outcomes are comparable with, we know that maternal outcomes are way better, but that the neonatal outcomes are comparable with surgical interventions or other options for birth. And we tell everybody that, not nearly often enough, I think, and we probably, I don't know if we collect 10% of the births we get, maybe. I don't know, you see them come in, Rixa, I don't, but it's something that we would, I think it is something that our growth and standing as an organization is kind of gonna be the bedrock of our organization going forward, but we've got to collect it and get it out. Terry, there's a form. Rixa, you can answer that better than I can.
Yeah, I just typed the answer. If you go to Breech Without Borders, our research page has the data collection sheets that you can download. It has instructions on where to send them. Down the road, we're working on an electronic submission form so that instead of having to fill out the sheets and scan them, we'll have a way to fill them in online, and it'll just update into our database. That takes time and money and technological expertise. And I'm trying to learn how to do it myself, but I'm not trained in computer science. So it's slow. If anybody knows an expert who can help me set something like that up, I would love that. If not, it'll just take me some time to figure it out. So yes, but pen and paper still works. Very low tech, but it'll do.
Okay, well, thank you so much, guys. It's been incredibly valuable, what you've been doing in Australia and New Zealand, and just obviously all around the world. And we've done some great webinars here, and thank you for doing what you're doing, because you're making a difference, you're making an impact. And particularly when, I guess, you're in New Zealand in 2019 and you come back 3 years later, and you're able to see that difference, and you can see more physicians getting on board, which is pretty critical to things rolling out and changing. And I really love that particular comment around that there just needs to be a flip, and it's building that momentum to that point where it becomes almost shameful to not be supporting. Because and we're going to and you guys are the pioneers on this, so thank you so much. And thank you to those who were here live today, and those who are watching it later down the track. And we just here at IMCO, we just want to wish everybody a wonderful rest of the day, and thank you so much to everybody.
Thank you.
Bye.
Bye.